I would say that the most actionable mutations that impact surgical decision-making, breast cancer treatment, still are BRCA1 and BRCA2. So the same two genes that have been most important for the last 2 decades. There are other more rare genes such as P53, P10, CDH1, STK11. These are what we refer to as the high penetrance genes, ones that carry a lot of breast cancer risk and may push or encourage a patient to be more aggressive in terms of their surgical options or their other preventative options. I think where we struggle are these moderate penetrance genes, these ones that are still pretty rare in the population but carry what I would refer to as medium or moderate risk of breast cancer. What we struggle with right now is knowing exactly what is the risk that we would assign to any one of these genes. And once we find them, what do we do about it based on that estimated risk? So, and I mentioned in my talk, PALB2, ATM, and CHEK2. Those are probably the 3 that we're coming across most often in the clinic. When we send off a breast cancer gene panel and those return with a germline mutation in one of these 3, it's not a straightforward decision-making process. It's not obvious that a person with breast cancer should get a mastectomy or double mastectomy. It's not obvious about whether we should remove their ovaries or not. And it becomes complicated when you're tying that to breast cancer treatment, and becomes that much more complicated when you're starting to test unaffected family members. And how do we counsel those unaffected women about their own risks and what preventive actions they should take? So my hope is in the coming 5 to 10 years, between pooling of data, shared databases, more research into this, we'll be able to better elucidate what these actual syndromes are, specifically for PALB2, ATM, CHEK2, and some of the other more moderate penetrance genes, and come up with more informed guidelines about the best options for these women.